Good afternoon, everyone. I'm Molly Perkins, and I'm a member of the Conference Scientific Committee and would like to welcome you all to this first abstract session that will focus on important clinical aspects of HIV and aging. We'll have 5 abstract-driven presentations followed by a question and answer session. So now I'd like to turn it over to the presentations. Thank you.
Hello, everybody. It's my honor to present here. I would like to thank the committee to give me the opportunity. This is the title of my presentation with the reference number 1, so whatever it means, it's kind of lucky for me to have this number. I have no conflict of interest to disclose. And sleep disturbances are common in people living with HIV infection, or PLWH for short. When talking about sleep disturbances, people on first thought usually think about nighttime sleep disorders, including insomnia and obstructive sleep apnea syndrome, for example. The prevalence of insomnia in U.S. adults is about 40%. However, it may be as high as 70% in PLWH based on a review paper published in 2013. Sleep disturbances have been linked to adverse health consequences. However, one important aspect of sleep behavior is sleep during daytime. So disturbed daytime sleep behavior is yet another important aspect of the disturbances in sleep, while it is kind of understudied. So those may include frequent sleepiness during daytime or frequent and longer daytime naps. For example, in a previous study of early treated BLWH, the prevalence of frequent sleepiness is about 10% increase compared to the uninfected controls. So prior studies have been linked to excessive daytime sleepiness and daytime napping to cognitive performance in general population. For example, those studies shown here, including some of the very recent research. So given those previous results, our hypothesis here is that perturbed daytime sleep behavior, specifically frequent daytime sleepiness or frequent daytime napping, is negatively associated with cognitive performance in a population-based cohort, and that HIV infection moderates this relationship by exacerbating this negative association. So to address our hypothesis, we were using data from the UK Biobank, which is a population-based longitudinal study. Included over 500,000 UK men and women aged between 40 and 69 years old. It has extensive questionnaires, physical measures, and biochemistry samples and measurements. And hello, everybody. It's my honor to present here. I would like to thank the committee to give me the opportunity. This is the title of my presentation with the reference number 1, so whatever it means, it's kind of lucky for me to have this number. I have no conflict of interest to disclose. And sleep disturbances are common in people living with HIV infection, or PLWH for short. When talking about sleep disturbances, people on first thought usually think about nighttime sleep disorders, including insomnia and obstructive sleep apnea syndrome, for example. The prevalence of insomnia in U.S. adults is about 40%. However, it may be as high as 70% in PLWH based on a review paper published in 2013. Sleep disturbances have been linked to adverse health consequences. However, one important aspect of sleep behavior is sleep during daytime. So disturbed daytime sleep behavior is yet another important aspect of the disturbances in sleep, while it is kind of understudied. So those may include frequent sleepiness during daytime or frequent and longer daytime naps. For example, in a previous study of early treated BLWH, the prevalence of frequent sleepiness is about 10% increase compared to the uninfected controls. So prior studies have been linked to excessive daytime sleepiness and daytime napping to cognitive performance in general population. For example, those studies shown here, including some of the very recent research. So given those previous results, our hypothesis here is that perturbed daytime sleep behavior, specifically frequent daytime sleepiness or frequent daytime napping, is negatively associated with cognitive performance in a population-based cohort, and that HIV infection moderates this relationship by exacerbating this negative association. So to address our hypothesis, we were using data from the UK Biobank, which is a population-based longitudinal study. Included over 500,000 UK men and women aged between 40 and 69 years old. It has extensive questionnaires, physical measures, and biochemistry samples and measurements. And it obtained general consent from participants for follow-up through all health-related records. And this is the general setup of the UK Biobank. It's not specific for this current study, but some of them do relate. For example, the cognitive tests and questionnaires, including questions that document daytime sleep behavior, and some other tests, including biomarkers, may provide important, covariates for our analysis. To assess the daytime sleep behavior, we were using participants' self-reports. Basically, they were asked these two questions upon entering the study and given different options to choose from, and we were using those options directly as a categorical variable. And for the cognitive test, we were using scores from those tests. Basically, they cover the majority of the UK Biobank participants, although other tests are available as well. So for the reaction time test and pairs matching test, the greater the value, the worse the performance. For the fluid intelligence test, the greater value, the better the performance. And prospect memory test score is basically a dichotomy, either correct or incorrect. And we excluded participants who had missing data for both exposures or missing data for all cognitive outcomes. And HIV infection was inferred from the International Classification of Disease version 10, or ICD-10 for short, or self-reported. And this is the demographics of our participants. So basically, we identified 560 participants as HIV infected, and all the rest participants were non-infected controls. And basically, those PLWs were younger and had a great portion of male participants, non-white participants, or college-educated participants, and they were more socio-economically deprived, as shown by the Townsend Deprivation Index, or TDI for short. Other covariates include other sleep disorders, movement ability, and medical conditions as well. So results. So this picture is basically showing the reaction time across different frequencies of daytime sleepiness or daytime napping. And we can see that the reaction times increased with the frequency of daytime sleepiness or daytime napping in the uninfected controls, meaning that basically the performance in reaction time, or the performance in information processing speed, is worsening with the frequency of daytime sleepiness or daytime napping. And also, HIV participants performed generally worse than those uninfected controls. And most interestingly, HIV infection exemplified the increase of the reaction time with the frequency of daytime sleepiness or daytime napping by about 3 to 4 times. And this is the detailed results for the reaction time as well as for other cognitive domains as well. And we can see that basically the interaction between HIV and daytime sleepiness or daytime napping is only significant in the first domain, although the worsening of the performance with the frequency of daytime sleepiness or daytime napping is true for all the cognitive domains, and the worsening of the performance in HIV group is only significant in the first two tests. Okay, so this is the short summary. So basically, participants who had sometimes or often daytime sleepiness showed worse cognitive performance in all 4 cognitive domains, and HIV participants showed worse cognitive performance in mainly the information processing speed and episodic visual memory. So those are from the first and the second. The first test is the reaction time, and the second is the pairs matching for episodic visual memory. HIV infection significantly amplified the adverse effect of daytime sleepiness or daytime napping on information processing speed, and some limitations. I'm gonna just skip them. And okay, I'd like to thank our co-authors, Dr. Kunhu, Monty Montano, and Li Gao. Queen's my mentor, and Monty is my mentor on HIV and aging research. So thanks for the mentoring. Also, would like to thank our other members in our lab, and special thanks to the NIH Center for AIDS Research and HIV and Aging Internship Working Group for the generous sponsoring my registration, and many thanks to our other sponsors as well to support our research, and thank you so much for your attention.
I would would like to thank the organizers for giving me the opportunity to present our results on behalf of my co-authors related to associations between falls and medications with neurocognitive adverse effects among women with and at risk of HIV infection within the WISE cohort study. We are all aware of the demographics of people living with HIV in industrialized countries in terms of the aging population, as well as that at the present time the number of people living with HIV over 50 is significantly increased and over 50%. We also know that the non-AIDS comorbidities, including neurocognitive decline and falls, are similar to the general older population but occur at a younger age. Risk of falls in the general population is associated with use of medications with neurocognitive adverse effects that I will further call NCAE drugs, including those with anticholinergic properties. Our objective was to evaluate the impact of NCAE medications, including those with anticholinergic properties, on risk of falls in women with and without HIV. So, the WISE is a prospective multicenter cohort study that enrolled women with and without HIV infection at several sites across the US. All sites but LA contributed to 4 data. So participants reported antiretroviral and non-antiretroviral medications taken since the last visit, especially drugs with anticholinergic properties or those that are known to be further associated with cognitive decline. Participants also completed self-questionnaires about number of falls during the previous 6 months, with 4 having been defined as an unexpected event with loss of balance and landing on the floor or hitting an object. Univariate and multivariate logistic regression models were used to compare single and multiple falls versus no fall in the prior 6 months. Multivariate models were each sequentially adjusted for HIV serostatus and Y study site, sociodemographics, clinical characteristics, substance use behaviors, as well as HIV disease-related characteristics among the subset of women with HIV. So let me focus on participant characteristics. The study population included 1,315 women with HIV and 557 women without HIV with a completed falls assessment between 2014 and 2016. At the index visit, women with HIV were older with a mean age of 49 years versus 47 years in HIV negative, and were more likely to be HCV co-infected, to have renal dysfunction, and to report symptoms of peripheral neuropathy. Women with HIV were less likely to be obese and to report current smoking, current illicit substance use, and heavy alcohol use. Overall, women with HIV reported greater use of NCAE drugs in the prior 6 months compared to HIV-negative women, which was mainly driven by antidepressants use. When NCAE medication burden was considered, use of more than 2 NCAE drugs was associated with a greater odds of single and multiple falls. The same association was observed between total anticholinergic and non-anticholinergic burden, but was much stronger in the case of anticholinergic drugs, because taking even just one drug with anticholinergic properties was significantly associated with single and multiple falls. In conclusion, we observed that greater number of NCAE drugs, including those with and without anticholinergic properties, were independent predictors of increased risk of future falls among middle-aged women with and without HIV infection during a 6-month period. Associations appear to be incremental between number of drugs used and fall risk. And even if additional studies are needed to elucidate our results, we certainly have to find new approaches to manage aging people living with HIV, such as medication simplification, deprescribing, and avoidance of drugs with overlapping neurocognitive toxicity. So I would like to thank all MWCCS investigators and especially Angelique, Todd, Christine, Leah, Donald, Q, and Benny, as well as all WISE and MWCCS participants. Thank you for your attention.
Good afternoon, and thank you for the opportunity. My talk is in HIV and age at diagnosis of heart failure. People living with HIV experience age-related illnesses such as dementia and atherosclerotic cardiovascular disease at younger age, suggesting the presence of premature biological aging in this population. Chronic inflammation is thought to be a key factor driving the accelerated aging process in HIV-positive individuals. As shown in this diagram here, HIV-positive individuals have HIV-related factors and antiretroviral treatment-related factors that influence their biological clock as well as cause age-related diseases. They also affect genetic and epigenetic change in this population. Several studies have shown that HIV-positive individuals have higher risk of heart failure compared to their HIV-negative counterparts. However, it's not known if heart failure occurs at younger age in this population. And crude comparison of age at diagnosis of heart failure between HIV-positive and HIV-negative individuals is not sufficient because it does not account for difference in the underlying age structure, unless you have a matching cohort of HIV-positive and HIV-negative patients age-matched and follow them. Therefore, we sought to compare the age at diagnosis of heart failure between HIV-positive and HIV-negative individuals, accounting for population age structure. We used the VA data on HIV-positive and HIV-negative veterans. Adjusted median age of HIV-negative veterans with heart failure was calculated by applying statistical weights derived from the age structure of the HIV-positive veteran populations. Statistical weights were calculated by dividing the number of participants within each one-year age strata of HIV-positive veterans for each calendar year by total number of HIV-positive veterans for the corresponding calendar year. We also calculated age-specific heart failure incidence and relative risks for HIV-positive versus HIV-negative veterans for each 10-year age group. The idea being, if HIV causes heart failure to be diagnosed at younger age, then the relative risk will be significantly higher at younger age groups and then becomes progressively slower at the older age group. Secondary analysis involved the following subgroups: inpatient versus outpatient index heart failure, reduced versus preserved ejection fraction, older versus younger age group, and heart failure index state before or after 2009, and initial heart failure diagnosis in community or VHA hospital. And for the HIV positive veterans, we also looked at the age at diagnosis of heart failure by CD4 count, viral load, and ART use. Statistical analysis was performed using SAS and STATA. This is the baseline characteristic table. As you see, we had 1.4 million veterans with heart failure who were HIV negative and 5,000 who were HIV positive. The median age was 72 years for the HIV negative veterans and 58 for the HIV positive veterans. Predominantly male population, and a larger proportion were black among the HIV positive veterans. and there was higher prevalence of chronic kidney disease, and there were more smokers. Also, other social factors such as homelessness and depression were more prevalent in HIV positive veterans. The ejection fraction was compared with the two groups, so was the BNP. These are HIV. Second table shows the HIV specific factors, viral load, CD4 count, and ART in the population. Heart failure diagnosis age was 72 in the HIV negative veterans. This is the crude age, and 58 in the HIV positive veterans, 14 years difference. And predicted adjusted age for sex and race was still significantly different, about 16 years between HIV positive and HIV negative veterans. Now, once we took into account the difference in age structure, we made adjustment of the median age of HIV negative veterans for the age structure of HIV positive veterans. The median age in the HIV negative veterans was 64 years, leaving still 6 years absolute difference between the two populations, which was statistically significant. And these findings were also consistent when we looked at index heart failure that was inpatient versus outpatient. There was still HIV positive patients were still diagnosed with heart failure 6 or 7 years earlier by ejection fraction. When we looked at younger age at onset of heart failure or older age before after 45 years, or the time period of diagnosis before 2009 or after 2009, and also whether disease was diagnosed in community or the VHA. HIV positive veterans with lower CD4 count, higher viral load, and not only ART treatment, had younger age at diagnosis of heart failure. This is a standardized incidence ratio, as shown here. The relative risk was significantly higher at younger age groups and became progressively smaller in the older age group. In summary, HIV positive veterans are diagnosed with heart failure at significantly younger age compared to their HIV negative counterparts. The results were constant across several important subgroups. Heart failure was diagnosed at younger age for HIV positive veterans with lower CD4 count, higher viral load, or those not on ART. And the study limitations include retrospective in nature, observational in nature, this was record linkage data. 97% were male. There was limited access to non-VHA records and competing risk was not accounted for. These findings imply that preventive measures such as screening for heart failure and treatment of risk factors, example hypertension, diabetes, may have to occur at earlier age for HIV positive veterans. Future studies using non-VHA data and with larger representation of women should help to make these findings more broadly generalizable. This is my funding support, and these are my mentors and analysts. Thank you.
Hi everyone, my name is Vivian Chen and I'm a current pharmacy student at the University of California, San Francisco. Today I will be presenting my team's research results on the evaluation of prescribing issues in older adults living with HIV. I have no conflicts of interest. Polypharmacy is defined as taking 5 or more medications and is more common in older adults often living with more chronic illnesses. It is associated with an increased risk of mortality, morbidity, falls, additive toxicities, drug-drug interactions, potentially inappropriate medications, and adverse events. Antiviral agents for the treatment of HIV also have a high potential for drug-drug interactions. The San Francisco General Hospital Ward 86 Clinic is a primary care clinic for HIV-infected individuals. The Golden Compass program offers older patients comprehensive multidisciplinary care, including a visit with a clinical pharmacist. Our clinical pharmacist, Janet, recognizes and resolves potentially inappropriate medications, also known as PIMS, drug-drug interactions, or DDIs, and adverse effects. She also performs a full medication reconciliation and addresses patient education and adherence strategies. Our study goals were to describe the potentially inappropriate medications in our study population and evaluate the effect of a pharmacist's clinical visit. This was a single-center retrospective study done at San Francisco General Hospital, Ward 86 Clinic, between July 2016 and December 2018. We collected data at 2 different time points, the initial consult visit and a 6-month follow-up visit. The data collected included potentially inappropriate medications, as described by the Beers start and stop criterias, the patient's medication list and pill burden, and drug-drug interactions. We then assessed the differences between the 2 visits using a parity test. This table shows our participant characteristics. Our study population included 123 adults living with HIV. The mean age was 64, with a range between 50 to 81. The majority of our patients were male. 98% of the patients were on ART therapy, and 92% had an undetectable viral load. In our study population, the majority of the patients were on an integrase inhibitor at 78%, and about a quarter each were on protease inhibitors and NNRTIs. These were often in combination with NRTIs. 94% of the patients had polypharmacy, not including the ART medications. 81% had 1 or more drug-drug interaction, and 62% had 1 or more potentially inappropriate medication. The top comorbidities were depression, hypertension, hyperlipidemia, and falls. We then looked at the potential changes in total pill burden or medications between the initial and 6-month visits. At the initial visit, a clinical pharmacist performed a full medication reconciliation and addressed potential prescribing issues. Just to orient you, the numbers on top of the bars indicate the means of the study population at the initial and 6-month visit, and the p-value and differences are from the parity test, looking at differences for each individual between the 2 visits. At the initial consult visit, the average total ART pill burden was 2.5 pills per patient. Patients were taking an average of 13.4 total medications, including as needed, ART, current and unknown medications. The average total daily pill count per patient was 16.4 pills. As you can see, none of the changes were statistically significant, but we did see a trend towards decreased ART pill burden. The most common medications besides ART medications were atorvastatin, aspirin, benazepril, and gabapentin. We then looked at the prescribing issues, including PIMS and DDIs. We saw a significant reduction in total PIMS between the initial and 6-month visits. Of note, we did not record any stop medication problems that were in addition to the Beers criteria, which is why the stop medications bar looks so low. The most common prescribing issues included NSAIDs, proton pump inhibitors, benzodiazepines, duplicate drug class prescriptions, opioids without laxatives or with a history of falls or fractures. Patients had on average 1.6 potentially inappropriate medications at the initial visit and 3.6 drug-drug interactions. For the drug-drug interactions, we did not see a significant reduction between the initial and 6-month visits, but we did see a trend towards a decrease. In conclusion, we found through this study that the majority of older adults living with HIV have polypharmacy. 81% had 1 or more drug-drug interaction, and 62% had 1 or more potentially inappropriate medication. A pharmacist intervention significantly decreased the number of PIMS with a trend towards decreased ART pill burden. For study limitations, one of our major limitations was that our electronic medical record system did not always retain the changes that were made at the initial visit, which was oftentimes very frustrating. In addition, as 6 months passed between the initial and 6-month visits, disease states naturally progressed, and medications may have been added that were beneficial to the patient. Thus, total pill burden and medications were not always reflective of the positive changes. In the future, we will be better characterizing the drug-drug interactions that came up frequently, looking at changes in medication regimen complexity score, and potentially designing future studies to include non-intervention controls. Finally, I would like to thank the leadership, staff, and patients at San Francisco General Hospital, Ward 86 Clinic, as well as the Golden Compass team. I'd like to thank my preceptors, Janet and Meredith, our statistician, Ying, and my entire pharmacy research team. Thank you so much for attending this presentation.
Good afternoon, everyone. I'd like to thank the workshop committee for giving me the opportunity to present our work on transportation barriers and how they are associated with health status in middle-aged and older adults living with HIV in the Deep South. So as many of you may know, the epicenter of the HIV epidemic in the United States has shifted over the decades to the South. The Deep South, which is comprised of Alabama, Florida, Georgia, Louisiana, Mississippi, North and South Carolina, Tennessee, and Texas, continues to be disproportionately impacted by HIV/AIDS, especially for African Americans and men having sex with men. The disease concentration and poor health outcomes seen in people living with HIV in the Deep South is driven in part by socioeconomic factors. Therefore, identifying and addressing these factors will help us improve health outcomes for people with HIV and better connect them with the services and care that they need. One of these factors is transportation. Transportation is a social determinant of health that touches multiple aspects of an individual's life across the lifespan. When assessing the significance of transportation barriers in individuals living with chronic disease, including HIV, research has indicated that greater transportation barriers are associated with more canceled or missed healthcare appointments, delay in care or lapsed care, poor medication adherence, and overall poor disease management. Lacking in the HIV literature, though, is how transportation barriers are associated with both physical and mental health, which was of particular focus for this study. To do this, we used a sample of 261 middle-aged and older people living with HIV from a larger study which was conducted at the University of Alabama at Birmingham. We used questions from a series of questionnaires focused on mental and physical health, medication adherence, barriers to care, and transportation usage. Additionally, we used lab records from a university-affiliated clinic to attain CD4 counts, viral load, percent viral load detectable, and HIV duration in years. To summarize our sample, they were on average 51 years of age and had roughly a high school education. They were largely male and African American race, consistent with the sample demographics of HIV/AIDS in the Deep South. Approximately just over 3/4 of our sample were currently not employed, and about 60% were disabled. Half of our sample were considered to have neurocognitive impairment based on the Global Deficit Score, or GDS. And just over a quarter of the sample had detectable viral load with a median CD4 of 636 and a median HIV duration of 18 years. When looking at correlations between transportation barriers and demographics, we found that a greater lack of transportation to access necessary services and care was associated with non-white race, having a lower household income, and having fewer years of reported education. For HIV and AIDS disease characteristics, we found that a greater lack of transportation was associated with greater medication non-adherence, having a higher viral load but not percent undetectable, and having ever canceled or missed a healthcare appointment, and having greater depressive symptoms. When assessing regressions on the Mohs HIV physical and mental health outcomes, after accounting for HIV duration in years, CD4 count, viral load, race, socioeconomic status, and depressive symptoms, a greater lack of transportation to access necessary services and care was associated with worse general health perceptions, worse pain, social functioning, health distress, and quality of life over the past 4 weeks, and worse physical health and emotional conditions compared to 4 weeks prior, or what we call health transitions. In conclusion, access to transportation is a key social determinant of health that promotes health equity and quality of life for people with HIV. This may be ever more important for those who are not medically fit to drive, who lack the financial means to drive, or live in geographic areas with underdeveloped public transportation. It's also important to note that all these issues are very pertinent for people living with HIV who also live in the Deep South, as many aging individuals live in rural areas where public transportation and rideshare options are not available. Additionally, more research is needed to assess how transportation barriers may affect the severity or long-term progression of HIV/AIDS, as well as HANA conditions over time. This will ultimately require unique data sources and collaborations across institutions. And lastly, from a healthcare provider implication standpoint, these findings are in line with the literature that precedes it, speaking loudly to the role of healthcare providers in transportation. Providers at all levels are encouraged to assess driver fitness as well as transportation barriers in this at-risk aging population, as they are our first-line defense to helping us connect people with HIV to care and services that they need within their communities. And so with that, I would like to thank my co-authors, Dr. Despina Stavrinos, Dr. Peria Fazeli-Wheeler, and Dr. David Vance, our departments at the University of Alabama at Birmingham and the University of Kentucky, as well as the STAR training program at the University of California at San Diego. I'd also like to acknowledge all of our funding from the National Institutes of Health that supported this project, as well as the Department of Transportation. Thank you for your time and attention.
I'd like to thank the presenters for 5 very stimulating talks. Now we have time for some questions, and we'll start with Dr. Chen. Is it possible to find out what the clinical indications were for prescribing gabapentin? Lots of toxicities and often overprescribed, unfortunately.
Thank you for the question. Unfortunately, we did not always track which clinical indications when we recorded each drug, but that's definitely something that we can look into for the future.
Thank you. So the next question is for Dr. Lee. Given the sample size differences in your study, did you consider matching 1-to-1 instead? Which do you think is the best intervention target, modifying the sleep behaviors or trying to change cognition directly?
Yeah, thanks for the question. So for the first half of the question, I think it's a methodology concern. So basically, I used the regression to take advantage of the big sample size we have. But I agree with you that we can try other matching methods such as a propensity score based on the social, psycho-economic status. And I think the second part of the question is kind of, a chicken or egg question for me, I think, because so far we don't know which is, the consequence with the course. So we just report the association between daytime napping behavior and, cognitive performance. But I think an interventional study later will help us address this issue as well, I think. So yeah, I think that's the answer. Thank you.
Thank you for your answer. The next question is for Dr. Pasomas. Do you have a list of the specific NCAE medications that you looked at?
Yeah, thank you for the question as well, Janet. The list is on slide number 5. So drugs included painkillers, antipsychotic drugs, beta blockers, gastrointestinal drugs, and we will further analyze more data about polypharmacy as you did in our cohorts. So yeah, the analysis is still ongoing.
Thank you. And we actually have another question for you. Did your data involve OTC and herb drugs?
No, this was for Dr. Chen.
Dr. Chen.
Yeah.
Your question, I'm sorry.
Yeah, this is my question, yeah.
Thank you for the question, Christina. Yes, we did include OTCs and herbals, and one of the most common OTCs was actually ibuprofen.
Okay, thank you.
Thank you. And this question is for Dr. Urquhart. There were big imbalances in race by HIV serostatus. How did you handle this in your analysis?
Thank you for the question. As usual, there is a race imbalance whenever we look most of the cardiovascular factors comparing HIV and non-HIV. What we did was we looked at adjustment for race and sex, and we predicted the age, and the age difference was still 16 years after accounting for race and for sex. So the difference we noted, the younger age at onset of heart failure was not due to the imbalance in race. And so we went ahead and with the further analysis.
Thank you. Dr. Lee, another question for you. Frailty seems connected to daytime sleeping. So do you recommend more exercise and physical activity to fight against frailty?
Yeah, that's a great question. So I think, it's kind of a similar question for me. So frailty is associated with daytime sleep behavior, but I think also we don't quite know yet, whether, frailty is a consequence of frequent daytime sleepiness or is a cause. So I think it's also kind of a chicken or egg question for me. And I think the other scenario is that both frailty and frequent daytime sleepiness is is the consequence of the underlying infection just because of the infection, chronic infection. So, but I think in general because I'm studying sleep and circadian physiology, I think in general exercise may help with improving the circadian rhythm and also sleep, I think. So, but I think people need to pay attention to the level of the exercise as well. So, yeah.
So, Vivian Chen, this pharmacist intervention seems very valuable. Do you have any plans for translating it to other clinics?
As of right now, we do not have any plans to start this kind of research project in other clinics. However, we will be continuing this research with the Golden Compass program at SFGH Ward 86.
Dr. Iroquois, I'm curious, do you know how these findings from your study compare to the general patient population or the civilian patient population?
We don't actually. So this is probably the first one to look at heart failure age at onset and compare it between HIV and non-HIV population. But as you are aware, with other diseases, we see that people with HIV have younger age at onset. Not always, but with some of them, with some cancers, and we see that with atherosclerotic cardiovascular disease as well. When you look at coronary calcium scores, they seem to have more advanced calcium score for their age. Some people have looked at their vascular age, and it looks like they could be they have a calcium score burden that's equivalent to a few years older person. And so, but for heart failure itself, this will be the only one I'm aware of.
Thank you very much. And I'd like to thank all of the presenters. We've come to the end of our session. So thank you very much. And we'll close now.